Good evening, everybody. Thank you for attending the teaching tonight. We will be welcoming Dr. Mahmoud Mustafa. He will present a very interesting lecture about hyponatremia. I just want to remind you all, if you please put your mic as mute, and if it's possible, keep the camera on, just to make the session interactive as possible. The lecture should take about 30 minutes, and then there will be 15 minutes after that for questions. The feedback forms will be shared on the group, hopefully today after the session. Now over to Dr. Mahmoud Mustafa for his presentation.
Hello, everyone. This is me, Mahmoud Atteya Mostafa. I work as medical SHOs in Royal Albert Edward Infirmary in Wigan, and our lecture today about how to approach a patient with hyponatremia. This is going to be our objectives for today. So starting by defining hyponatremia and what are the types, how to approach a patient with hyponatremia, when to admit the patient, and what's the workup and classification of hyponatremia, and at last, what's the management of patient with hyponatremia. So starting by defining hyponatremia, it's defined as serum sodium of less than 135 millimole per liter. We know that the normal range is 135 to 145 millimole per liter. Why hyponatremia is important? Because we do have 15% of admitted patients in the UK who has hyponatremia, and 25 of the patients admitted due to fall will be having hyponatremia. Also, hyponatremia increase the mortality. It can prolong hospital admission, and it can increase the risk of readmitting patients to the hospital. And if we can classify hyponatremia according to severity and onset, there's acute onset hyponatremia, which we are talking about less than 48 hours presentation, or chronic, which is more than 48 hours. According to severity, it can be classified into mild, moderate, or severe. Mild is over 130, but less than 135. Moderate is from 125 to 130. And then severe hyponatremia will be lower than 125. In mild and moderate cases, you might not have any symptoms at all, or the patient can present with nausea, confusion, or headache. In severe hyponatremia, the patient can present with more vigorous symptoms, up to having convulsions and coma in severe cases. So how to approach a patient with hyponatremia? Starting by history. We will need to know if the patient has any symptoms due to the hyponatremia. We need to have a drug history, because we do have drug-related hyponatremia. We need to know his past medical history, as some diseases can cause hyponatremia. A patient with sepsis or a burn can have hyponatremia due to third space volume loss, and we need to know his diet habits. Examination is very important in a patient of hyponatremia to determine if the patient is hypervolemic, hypovolemic, or euvolemic, because the causes will be different in each case. To examine for the volume status, we need to check his heart rate, if there is any postural change and blood pressure due to hypovolemia, check his jugular venous pressure, check the presence or absence of peripheral edema or clinical signs of dehydration. Well, from clinical examination, how to determine the patient is hypovolemic, he will be having tachycardia, postural hypotension, dry skin mucous membranes, low urine output, and reduced skin turgor. Hypervolemia, a patient will be presenting by generalized edema. He can have ascites, significant weight gain, and raised jugular venous pressure. Euvolemia is simply the patient doesn't have either of these. So the investigations, sometimes you will see the patient after he has been seen by the A&E staff, and this can take up to 12 to 24 hours nowadays. So repeating sodium to exclude rapidly decreasing hyponatremia will be useful. We will need to check the patient's serum osmolality, again, because different serum osmolality, as we'll see later, will have an effect on diagnosing the cause and also the management of the patient. We will need to check the urine osmolality, urine sodium, and to rule out other cause of hyponatremia. We can do urine analysis to rule out kidney disease, thyroid functions, BNP, cortisol levels, 9 AM cortisol level, and liver functions as well, lipid profile, and blood sugars. And we will see in the next few slides how each of them can affect the hyponatremia. These are the admission guidelines according to NICE guidelines. So if the patient is presenting with acute onset hyponatremia, or the patient is having severe hyponatremia of less than 125, or if the patient is symptomatic, or he's hypovolemic. If the patient is having moderate and asymptomatic hyponatremia, you might need to discuss with the endocrinologist for the need of admission. If you have diagnosed the patient as syndrome of inappropriate and diuretic hormone secretion and malignancy suspected, urgent 2-week wait referral will be needed. Otherwise, you will just diagnose, try to know the cause of hyponatremia and refer to the specialty according to the cause suspected. This is a simple diagram, or I'm not going to say it's simple actually. It's a diagram of how antidiuretic hormone will affect the distal collecting tubules and collecting ducts. So basically, it's antidiuretic hormone. So its main role is to retain sodium and water. Well, I can say this is the most important slide in this lecture. It gives you an idea of the whole workup and the management plan. So starting by confirming that the patient is hyponatremic by checking his serum sodium, and you will find that sodium is less than 135. Then according to the serum osmolality, you are going to have hypertonic hyponatremia, hypotonic hyponatremia, or isotonic hyponatremia. For hypertonic hyponatremia, this means the patient having concentrated sodium in his blood, and this is usually due to hyperglycemia, as in DKA, or due to hypertonic fluid administration. For isotonic hyponatremia, this is what's called pseudo-hyponatremia, and this happens in patients with high triglycerides or high proteins, such as multiple myeloma. The big issue will be with hypotonic hyponatremia. Here you need to assess the volume status of the patient, as we have mentioned earlier. and the patient will be either hypovolemic, hypervolemic, or euvolemic. So if the patient is hypervolemic, you will need to check urine sodium in all the hypotonic hyponatremia. In hypervolemic, if the urine sodium is less than 30, this means the kidney is not losing sodium in urine. And this can happen in patients with heart failure, liver cirrhosis, or nephrotic syndrome. Or the urine sodium will be more than 30, which means the patient is actually losing sodium in his urine. And this is usually due to chronic kidney disease. In hypovolemic hyponatremia, again, we'll check the urine sodium, and you'll need to know if the kidney is losing sodium or not. So if the patient is hypovolemic, such as in diarrhea, you are not expecting the sodium to be high in urine because the source of loss is non-renal. Or if the patient is having renal sodium losses, you will have urine sodium more than 30. In euvolemic, usually the urine sodium will be more than 30. And then it's according to the urine osmolality. If the urine osmolality is low, this is going to be primary polydipsia. Simply the patient is drinking too much water, or hypotomania, which means the patient is drinking too much alcohol with no salt-rich diet. Or if the urine osmolality is high, this can mean the patient can have syndrome of inappropriate antidiuretic hormone secretion, or it can be due to medications. I know it's lots of details, but it's just hyponatremia. So just a glimpse about SIADH. It's inappropriate excessive release of antidiuretic hormone. This can be from the pituitary gland itself, or it can be from a non-pituitary source. So a non-pituitary source can be such as a malignancy. That's why you'll find patients with hyponatremia in the hospital who are euvolemic, and we are suspecting SIADH. We usually will be asked to scan them for any source of malignancy. The diagnostic features will be for diagnosing SIADH. The patient needs to be euvolemic. The urine osmolality is usually greater than 100, and the urine sodium is greater than 30. But you need to exclude other causes. So the renal functions, the 9 AM cortisol and thyroid function should be normal in these patients. Then coming to how to treat a patient with hyponatremia, it's mainly dependent on the severity. Before the severity, it depends on the onset. So if we have a patient with acute hyponatremia, this patient will need to be given hypertonic saline infusion, usually in ITU setting. Supportive care, because we are expecting the patient to have symptoms, could be having low GCS or acute confusion, and start treating the underlying cause. But bear in mind that the rate of correction needs to be less than 8 millimole per day. In chronic hyponatremia, it will be according to the cause. So a hypovolemic patient, simply you will need to replace his fluid status. So we give isotonic fluid infusion and treat the underlying cause. In hypervolemic hyponatremia, you will need to do fluid restriction, treat the underlying cause, and you can start the patient on loop diuretic or spironolactone. Well, some of these patients can be started on vasopressin receptor antagonist, but you will need to discontinue fluid restriction. Then in euvolemic patients, you will need to start fluid restriction and treat the underlying cause. And again, if you are giving vasopressin, you will discontinue the fluid restriction and treat the underlying cause. I think this is going to be the end of the presentation. We have some examples here if you want to proceed with it.
Yes, carry on, please, doctor.
Yeah, I think we need to proceed. I'm so much confused now.
Yeah, I know, it's so confusing.
Yes, carry on, please, yeah.
Okay, so just back to this slide, we will need to determine the serum osmolality, and then the volume status, and then the urinary sodium. Just keep that in mind. So for the first patient, we do have an 18-year-old patient presenting with abdominal pain and vomiting. His serum sodium is 126, which will be a moderate hyponatremia. His serum osmolality is 310, which is high, and the patient is hypovolemic. What do you think could be the cause here?
DKA or alcoholic intoxication. There is something that increasing the osmolarity apart from the sodium.
Yep, that's right. And how you are going to treat him?
In this case, because it's clear that he's hypovolemic, I will start with fluids. 0.9% saline, and look for what is the cause, what other causes that make the osmolarity high.
Yep,
and treat accordingly.
Right. Definitely, yes. I do agree with that. Problem is, if I move to the next slide, you will find all the solutions. So what do you think?
I think it's better to be kept as quiz because the issue of hyponatremia is quite complex. Just we need to make it clear if we have understood anything or not yet.
Yeah, that's right. Okay. So going to the next example. So Dr. Rawia said this first patient is going to be probably DKA, and we will give isotonic solution. The next patient is going to be a 50-year-old male patient presenting with back pain, chronic fatigue, and pneumonia. His serum sodium is 129, again, moderate hyponatremia. Serum osmolality is 285. This is going to be an isotonic. And then the patient is euvolemic clinically. His hemoglobin is 90, white cell count is 15, and platelets 150. What do you think here? Just back to the slide to give you some hint.
Anyone wants to comment?
Sorry?
Anyone wants to comment, Dr. Ihab, Dr. Mohsen?
Yeah, I think it looks like it's isotonic hyponatremia and probably falling into pseudo-hyponatremic picture. Maybe a high protein with the back pain and the chronic fatigue, maybe myeloma.
Yeah.
Yeah, but I don't think pseudo-hyponatremic. I will go for Siada.
Siada needs to be hypotonic. This patient is actually falls in the isotonic hyponatremia here.
Okay. Okay.
Agreed? Okay, so the next patient is a 45-year-old female patient presenting with headache, vomiting, profound diarrhea, developed grand mal seizure while in CDW. Her serum sodium is 110. Her serum osmolality is 265. She's clearly hypovolemic, and urine osmolality is 120. Urine sodium is 15. What do you think is going on here? I can go back to the flow chart again.
It's probably volume loss from her vomiting and diarrhea.
Yeah.
I don't know which category she falls.
So back to the case here. We have severe hyponatremia, which is probably the cause of her seizure attack. Her serum osmolality is 265, which is hypotonic, and the patient is hypovolemic. And then her urine sodium is 15, which indicates the losses are not renal. And this is clear from the history itself. The patient has got vomiting and profound diarrhea. Okay. So the next patient, we're talking about 60-year-old patient presenting with orthopnea and abdominal distension. The serum sodium is 127, which is moderate hyponatremia. Serum osmolality is 268. This means hypotonic. He's clinically hypervolemic. Urine osmolality is 110. Urine sodium is 18, and his creatinine is 120. What do you think is going on here?
So
Anyone?
I think we are in the categories between the heart failure or maybe chronic liver disease, fluid overload.
Yep. Is it possible to be chronic renal failure?
No, because the sodium, urine sodium is a bit, it was 80. So this patient is not chronically releasing urine, sodium in his urine. It means that his kidneys, to some extent, are preserved. His kidneys.
Definitely, yes. I agree with that. Okay, so the last patient here, 75-year-old patient presenting with a fall, which is quite common. His serum sodium is 122. This is starting to be severe hyponatremia. His serum osmolality is 269, which is low. So we are talking about hypotonic hyponatremia. And the patient is eovolemic. His urine osmolality is 330, and urine sodium is 50. What do you think is going on here?
It's ADH.
Yep, probably. But we will need, as in this slide, we will need to exclude other causes. So you need 9 AM cortisol and thyroid functions as well before confirming the diagnosis of ADH. Okay, so this is the solution for the cases we have discussed. The first case is going to be hyperosmolar hyponatremia and probably DKA, and the treatment is just to start the patient on DKA protocol. The next case is pseudohyponatremia and probably multiple myeloma, giving the back pain, chronic fatigue. The third case is going to be hypovolemic hyponatremia, non-renal losses, probably due to the vomiting and profound diarrhea. And I'm sorry, the treatment is not going to be hypertonic fluids, so I just need to correct that one later. The third patient is hypervolemic hyponatremia due to heart failure, cirrhosis, or nephrotic syndrome. We will start with fluid restriction and give him some diuretics. And the last patient, again, it could be ADH. So you will start with fluid restriction. But just bear in mind, if you started the patient on tolvaptan, you will need to stop the fluid restriction. So that's the end of my presentation. If anyone has any questions.
Yeah, what is the I heard about an antibiotic from the family of don't remember the name. It's used for ADH hormone.
I think you're talking about the nucleocycline, and I
Yeah.
think it's used as second line if tolvaptan is not working. I'm not quite sure about it. I have never seen anyone using it before, but it's mentioned in the NICE guidelines.
Thank you. So in relation with alcohol abuse and hyponatremia.
Well, back to the flow chart. This patient with hyponatremia, or the patient who's going to have hypotonic hyponatremia and he's euvolemic and urine sodium is more than 30, an alcoholic patient who's taking, especially, it's called beer hypotomania, which means the patient is addicted to beer. He's taking large amounts of beer and with no salt-rich diet. I think that's why there's some connection between both of them.
I have an unrelated a question which is unrelated to hyponatremia. You mentioned on the third lady that she had seizures in CDW. What is CDW? Sorry.
Okay, so you are working in ICU. CDW is a clinical decision ward where you will keep patients from A&E until you have a decision about them. Sometimes you'll just give the patient some IV antibiotics and send him home to review him back in ASTIC or something like that. So the patient is not so critical to remain in the majors of A&E, but he still needs something before going home.
So it's like a waiting lounge for less ill patients.
We can say that, although everything is messed up these days because we started to have corridor patients. So the rules are not working very well these days, actually.
Maybe within the next month we'll have WC patients.
Actually, we have assigned they have assigned a corridor doctor to look after the patients in the corridor, because some of the patients will be seen and not reviewed in 48 hours because there is no one assigned to see patients in the corridor. Anyway, that's CDW.
Thank you. Okay, everybody. I think this is the this is the end of the lecture. I can still give some time for anybody who has questions. We still have a few more minutes.
Is it recorded?
Yeah, it is. Sorry, I should have.
I need to go back. Yeah, I need to go back. Yeah, I need to attend it again and again. It's a very clear, Dr. Mahmoud. Thank you very much.
Actually, but as I said, this flow chart actually will give you the clue to most of the cases.
Yes. Thank you very much. It was a very good lecture. We needed it.
Actually, I prepped this lecture because hyponatremia still makes problems for everyone. I mean, unless you are endocrinologist, you will have a problem with managing the sodium hypo and hypernatremia.
Okay, thank you very much, Dr. Mahmoud, for really very interesting and very important lecture. Thanks everybody for attending this session, and just a reminder, please be sure to fill the feedback, which I'm going to circulate shortly after the session. The feedback forms are 2 for every session we do, 1 for the presenter and 1 for organizing the session, so please be sure to fill both of the forms. Have a look on the previous forms also. If you missed any, just drop me a message. If you are not sure, I can have a look and see if you have filled this form or not. Okay, see you everybody next Friday, hopefully, and enjoy your weekend. Thank you very much.
Thank you. Thank you. Salam alaikum.
Alaikum salam.